done a number of things to adapt to the COVID-19 pandemic. The first thing we did was having to adapt everything that we did very swiftly from a fully face-to-face intervention and program to a fully virtual intervention and program. So up until the end of March, for 13 years, our intervention had been solely based on face-to-face training and face-to-face support for clinicians in general practice and, of course, for their patients. So what we did within a 6 to 8 week period was adapt all of our materials from face-to-face to virtual. So all our training is now available via webinars, and all of the support that our advocate educators offer and that the IRISi team offer is now made safe and streamlined to be able to offer in the fully virtual world that we're all needing to operate in.
So to adapt our programme for the COVID-19 pandemic, we did a few different things. So firstly, we developed and issued a number of guidance papers. One paper we issued was how to respond safely to domestic violence and abuse in telephone and video consultations, and that was received really positively. We also provided enhanced support to local teams, so the regional managers at IRISi who oversee the IRIS sites, they provided more regular check-ins to see how the sites were getting on and responding to the pandemic. We've also conducted some rapid research to understand the impact of our changing programme delivery. And we participated in national meetings in the response to the pandemic within the violence against women and girls sector.
When the pandemic ramped up in March and a national lockdown was imposed across the UK, general practice pretty much closed their doors to patients in efforts to keep the spread of the virus under control. And nationally, we saw a corresponding and really sudden drop in the number of referrals into the IRIS programme. General practice teams shifted rapidly, and so the vast majority of their consultations were conducted remotely instead, so telephone or video consultations. And gradually, as practice staff have adapted to this new way of working, and as IRIS advocate educators have had the chance to reconnect with their local practice teams and let them know that the IRIS service is still open, albeit in remote form, the referrals into the IRIS programme have gradually increased again. And by July, we're at the same levels as they were prior to the pandemic. Meanwhile, IRISi have been adapting the IRIS training package for general practice teams so it could be delivered virtually. And so it specifically covered what clinicians need to know about addressing and responding to domestic abuse in remote consultations. We ran a survey in July with clinicians, and that survey showed that around 16% of the clinicians who responded don't yet feel confident in addressing domestic abuse in remote consultations. However, only a tiny percentage of the clinicians who responded had yet attended any of the IRIS training sessions that specifically cover remote consultations. So we expect to see the number of clinicians who feel confident in addressing domestic abuse in telephone or video consultations increase over time as more practices undertake the revised IRIS training course, and we'll work hard to make sure that this is the case.